Right, we're just going to wait a minute or two for Dr. Noman and Dr. Humera to rejoin us, and then we'll start. We only have, I think, one more X-ray after this, and then I'll just briefly discuss some guidelines on ordering such X-rays, which X-rays are most useful, and what are the problems of plain X-rays when it comes to interpreting your midface trauma. So just going to wait a minute or two more, and then we'll start, inshallah. Right, I think. All right, any questions so far? If you guys have any queries for proceeding further, any point that you have not understood that you guys want me to repeat, I can repeat that, or any confusion, I'll try my best to clarify that. You can use yes, you have to use both for interpreting a Waters view. You can use Dolan, you have to use Dolan lines, and you have to use the Campbell lines. So yes, you have to use both when you're interpreting such an X-ray. All right. Okay. All right. So what is the anatomy that you see on an underexposed submental vertex view? Well, if since we are basically doing it for the zygomatic arch, I would advise you just to stick to the anatomy of the zygomatic arch in this case, because they've marked the maxillary sinus, but again, you can see that you cannot really visualize the maxillary sinus in this area. So this area under the zygomatic arch, this is the area they're calling as the zygomatic recess over here. So, and number 3, this is basically your zygomatic arch, and here number 7, this is the zygomatic process of your temporal bone. So that's why you find people calling it the zygomatico-temporal suture over here, this arch, which you can see over here, temporozygomatic suture or zygomatico-temporal suture. All right, and sometimes you can see the shadow of the coronoid, but again, for diagnostic or treatment planning purposes, this is not really a very useful X-ray, especially if you're talking about fractures of the coronoid process. You might be able to see the temporal fossa, which lies directly here beneath the zygomatic arch in this case. Right, but so main areas that we are interested in is basically the zygomatic arch. Okay, so we have a question over here. If we underexpose it, it will become darker, and if it is overexposed, it will result in a brighter image. No, actually, you've gotten it, Dr. Sagba, ulta kar diya aapne. If you underexpose it, तो आपको image ज़्यादा bright नजर आएगी, ठीक है? And if you overexpose it, तो वो blackish नजर आएगा आपको. Like देख लेना, ये वाला X-ray जो है, this is basically an underexposed X-ray. So it is overall looking quite whitish to you. All right. And let me just show you an overexposed X-ray कि वो कैसा लगेगा. Hang on. This is an overexposed X-ray. All right. So see, this is overall looking a lot more darker as compared to that one. All right. So this is an overexposed, means more dark, and if it is underexposed, so it is more white. All right. So now this is a very ideal, if one would say, a submental vertex view. But again, since I would stress that we are doing it basically for a zygomatic arch, so in this case, you really can't make out the zygomatic arch very clearly in this case. All right. But in your most of your maxillofacial radiology books, since from mostly for historical purposes, like I said, if you were planning an osteotomy of the mandible and you wanted to see the mediolateral dimension of the mandible, So you could have done a submental vertex view, or here you can see the sphenoid sinuses very clearly. So in such a case, you wanted to evaluate the sphenoid sinuses for any pathology. This is a view that you could have done. So since that is not clear, very clear over here, so it's maybe a bit difficult to say. The zygomatic arch you can't really see very clearly in here. So this is why we don't do an overexposed X-ray in such a case, right? Okay. So again, we have an illustrated diagram here of the anatomy, but like I said, since you're doing it basically for the zygomatic arch, उसकी anatomy मैं already आप लोगों को दिखा चुका हूँ. So just focus on that, and you really don't need to learn this unless you are academically inclined and you want to do it for your own learning. So then by all means, you can learn the anatomy you see on overexposed X-ray as well. All right, coming to the last X-ray that we'll be studying for today, that is called a true lateral skull. A true lateral skull is basically done, shows you the lateral view of the skull and the facial skeleton. And in a way, it is basically a non-standardized lateral ceph, because as you know, in the lateral ceph, you have the inclination of the skull is fixed according to the Frankfurt horizontal line, and there are some markers and pointers that are placed in the patient's ear just to orient their head in a position that if you wanted to do a post-op X-ray, so it would be standardized and the measurements would be, the orientation of the head would be reproducible. But as you can see, there are no such markers or pointers used in a true lateral skull. So that's why maybe the position of the head may not be stable. So you really can't evaluate outcomes of your orthodontic treatment on such an X-ray. You will have to do a proper lateral ceph if you wanted to do that, check the outcomes of orthodontic treatment. So it's basically a non-standardized lateral cephalogram, and it is basically indicated in fractures of the cranium, the cranial base, mid-face fractures, if possible, to show the downward and backward displacement of the maxilla, which may produce premature posterior bite resulting in anterior open bite. All right. So you can also do it to investigate the frontal, sphenoid, and maxillary sinuses, because you can see those somewhat on a true lateral skull. Other than that, in somewhat previous times, we used to also do it to evaluate the Paget's disease of bone, multiple myeloma, and hyperparathyroidism. Other conditions which may be affecting the sella turcica area, such as tumors of the pituitary gland, etc. You could also see those, but since these are not conditions that we are concerned about, so you can disregard them somewhat. But you can just, if you want to know them for academic purposes, well, here you are. So how it is taken? Well, it's taken relatively straightforward. The position is quite standard. Nasal bone is also covered. I'll come to that in the anatomy that you see, Dr. Noman. All right. जैसे आपको lateral ceph पे nose नजर आएगी, उसी तरह आपको lateral skull पे भी nose नजर आएगी. Both X-rays are quite similar in that regard. So basically, you have to sit the patient upright, in which the mid-sagittal plane of the patient, this is the mid-sagittal plane, this broken line that you see over here. So it has to be parallel to the X-ray film, and the X-ray beam is fired from the side of the patient. All right, so it's fired from the side of the patient, somewhat at the junction of the superior border of the body of the zygoma. This is how it's taken. So what is the anatomy that you see? So you can see the frontal sinus over here. You can see the sella turcica area over here. Here below the sella turcica, here you have the sphenoid sinuses over here. You have the external auditory matrix over here, mastoid air cells over here, the cervical vertebrae here, condyle over here, coronoid. And if you look very closely, maybe you can see the tip of the bony part of the nose over here. It's not very clear in here, but let me see if I can brighten it up for you. Again, not very clear over here, but it's you can see it. Anyhow, other structures that you can see, ethmoid sinuses, but again, I would suggest not to focus on areas posterior to the anterior part of the face. Here you have the maxillary antra over here, and you have the soft palate shadow over here. So this is basically the anatomy that you see on a true lateral skull. Here, let me elaborate it a bit here. So your structures number, let me just, they've not mentioned the nasal bone over here, but again, if you can get a decent picture out of it, you can see the nasal bone over here, but it's predominantly done for calvarial conditions basically, and for the sinuses. All right, so you have number 6 here is your frontal sinus, here is your maxillary sinus over here, here is your sphenoid sinus, and this area, you know, these few circles that you're able to see above the maxillary sinus, this is your sphenoid, your ethmoid sinuses in here. So how do you interpret this X-ray? Well, there is a zone type classification given for these lateral skull type of an X-ray, which is not something I would expect us surgeons to remember, because it's quite complicated. But still, here we'll give it a try. These are the 3 zones on which basically you have to interpret a true lateral skull. So let's start from the first area. The first area is your zone 1. So you start basically at the frontal sinus, then you'll have to go to the floor of the anterior cranial fossa, including the cribriform plate, then the interior walls of the middle cranial fossa, sphenoid sinus, vertical walls of the pterygopalatine fossa, pterygoid plates, posterior teeth, and then your anterior teeth. So whenever you're evaluating these zones, what do you have to focus on? You basically have to look for any separation or step deformity, all right, in the anterior or posterior walls of the sinus. And other than that, you have to focus on any disruption in the continuity of the floor of the anterior cranial fossa. Again, it will be difficult to do on this. CT is much better, but still, if you can pick it up, you know, that's good for you. Any, since this one is passing through the sphenoid sinus somewhat, so any fluid level, if you can see the sphenoid air sinus, any backward and downward displacement of the facial skeleton, and any gagging of the posterior teeth, and any degree of anterior open bite. So these are the 5 things you have to be particularly particular about whenever you're evaluating a true lateral skull. So coming to zone 2, zone 2 is a frontonasal suture in which you start from there, then you go to the lateral wall of the orbit, maxillary antrum, hard palate, and the anterior border of the maxilla. Zone 3 is the nasal bones, anterior wall of maxillary antrum, and anterior nasal spine. So let's just try to see if we can appreciate those things over here. So zone 1, as you can see, this is the maxillary sinus over here. You have the sphenoid sinus over here. In this area, you have the pterygopalatine fossa. Here you have the posterior teeth, and here you have the anterior teeth. This is basically your zone 1. So zone 2 starts from your frontonasal suture over here. Like I said, since the nasal bone is again a thin bone, so if you maybe underexpose the X-ray a bit, then you might be able to see the nasal fracture more clearly. But since you're doing this basically for the calvarium and the sinuses, then those areas will come out to be very white. All right. So this is somewhat an overexposed X-ray, so that's why you might not be able to appreciate the nasal bones very clearly in this. So zone 2, you can see it is passing through the frontonasal area. Then you have the maxillary sinuses over here. Again, tips the maxillary alveolus in this area over here, and the anterior maxilla or the palate in this area over here. Zone 3, it starts from again the nasal bone, anterior wall of maxillary sinus, and anterior nasal spine over here. All right. So these areas are a bit difficult to interpret this X-ray over here. But again, if you just remember these structures, so it may be somewhat possible for you to determine any fractures or any sinus pathologies. All right. Okay. So, all right. So now coming to the usefulness of these X-rays. Now this is a table that I've taken from Essentials of Dental Radiology by Eric Waits. So it has evaluated the relative usefulness of different X-rays, extraoral radiographs in terms of usefulness. The white ones that you see, those are low usefulness. The blue ones you see are of medium, and the orange ones are of high usefulness. Where there is no symbol given, that is an indication that this is not recommended. All right. So since we are basically evaluating midface structures, so let's see which X-rays tell you the best about the midface. So if you come to here, we have the first structure, which is here the anterior maxilla. If you really want to evaluate the anterior maxilla, so 2 X-rays will help you. Actually, 3 X-rays will help you with somewhat of usefulness, and that is the lateral ceph, the PA ceph, which I will teach you in the mandibular X-rays, and the panoramic or OPG, which again I will teach you in the mandibular X-rays. All right. So coming to posterior maxilla is seen quite clearly on the submental vertex view, but probably seen best on an OPG view. All right. What else? What about the orbit? So in the orbit, 2 X-rays are best at evaluating the orbit. That is your Waters view and your PA ceph. All right. PA ceph, like I said, I'll be teaching you in the mandibular X-rays. You can get a medium amount of information on a lateral ceph regarding the orbit. It's not very helpful in that regard. When it comes to evaluating the zygoma, so 2 X-rays are very useful. Your OPG offers you medium usefulness, but the Waters view is the best one. All right, it gives you a high amount of diagnostic information when you're evaluating the zygoma. When it comes to zygomatic arch, only this SMV or the submental vertex view is the best one, and the Waters view gives you a relatively medium amount of information. It may tell you the fracture is there, but again, you won't get a good idea of which direction is the displacement present. All right. So coming to the nasal bones के लिए you have the best one to give you information is the lateral ceph. Waters view again is maybe of medium usefulness in this case. The nasal cavity, if you want to evaluate it, so the Waters view gives you a medium amount of information, but the best one is the PA ceph. All right. Okay, coming to the maxillary sinus. So again, the Waters view is the best one for evaluating the maxillary sinus, and the lateral ceph and the panoramic view only offer you medium amount of information. Frontal sinus is best evaluated using the lateral ceph and the PA ceph. The Waters view can give you a decent amount of information as well. Ethmoid sinus is best evaluated, has no best X-ray as such. All 3 options, SMV, Waters, and PA ceph, give you a medium amount of information. Whereas for the sphenoid, the lateral ceph and the SMV view give you the best amount of information. Okay, so coming to the guidelines, this is a document which was prepared by the American College of Radiology. It's present on PubMed. You can get an abstract of that over here. However, if you guys want to read the full document, I can share it with you later on. This is called the ACR appropriateness criteria for imaging of facial trauma following primary survey. So it has 4 categories, in which the first category is usually appropriate. Then you have maybe appropriate disagreement, and usually not appropriate. And this relative radiation level, this nuclear sign that you're seeing, this is signifying how much radiation it is giving to the patient in a rough amount of millisievert radiation dosage as well, for pediatric and adults separately. So let's just have a look on what X-rays does the American College of Radiology recommend that you do for facial trauma following the primary survey. So if you are suspecting a patient who has tenderness to palpation or a contusion or edema over the frontal bone, so they recommend that you do a CT maxillofacial without IV contrast or a CT head without IV contrast. So radiography of the skull, which I've been basically teaching you, is considered as usually not appropriate, even though it has the least amount of radiation dose. But since it does not give you diagnostically appropriate information, so that is why it is not, it is considered as usually not appropriate. Yes, the PA-CEF is the PA skull, and the PA mandible is a different X-ray. Yes, you're right. The PA skull, they do it for, is usually done by orthodontists for facial asymmetry cases, right? Okay, so all the other X-rays that you see over here, like MRA, which is magnetic resonance angiography, MRI, head, cervical spine, MRI maxillofacial, CT maxillofacial with contrast, CT cervical spine, CT head with IV contrast, those with IV contrast, those are all considered as inappropriate X-rays. Yes, Waters is PNS view. The specific one is your OM 37 degree. All right, so you have to specify because usually our technicians don't recognize it as a Waters view. You have to specify whenever you're writing recommending a Waters view, you have to write advised X-ray PNS, and then the bracket you have to write OM 37 degree. That's when they will do a proper Waters view. Otherwise, they might just do a 0 degree or a 30 degree view. All right. So for frontal bone, CT maxillofacial or CT head with both without contrast are considered as appropriate, and skull radiography is not considered as appropriate, right? Okay. Then coming to the next one. All right, if the patient presents with upper jaw manipulation or pain overlying the zygoma or zygomatic deformity or facial elongation, malocclusion or improvital nerve paresthesia, so CT maxillofacial without IV contrast, this is considered as usually appropriate. And other X-rays such as radiography of the paranasal sinuses, like the ones I just taught you, the 0 degree view, 30 degree view, 37 degree view, Caldwell view, all of them are considered as not appropriate, even though there is less radiation level, but there is less diagnostic information. Basically, you might be able to diagnose a fracture, that the fracture is present, but it does not tell you anything about the displacement, any comminution, etc. So if for treatment planning purposes, these X-rays are not very useful. So you will sort of be reliant on your per-op findings, that whenever you open the zygoma through a Keen's approach or any other approach, then you might be thinking, oh, I need to plate this, or oh, do you think this will, just be stable enough with zygoma elevation. So this sort of information you don't get from your radiography of the paranasal sinuses, but this is information that you do get when you order a CT maxillofacial, right? Okay, then if a patient comes to you with a visible nasal deformity or palpable nasal deformity or tenderness to palpation of the nose or epistaxis, wherever you suspect nasal injury, so in that case, the best one is again CT maxillofacial without IV contrast. However, for nasal fractures, the radiography of the paranasal sinuses may also be considered as appropriate, right? So in this case, in nasal fractures, there is a role for the radiography of the paranasal sinuses. Ultrasound has also been found to be appropriate in diagnosing undisplaced fractures. So that has a role again, but since we us maxillofacial surgeons are not very comfortable or have any idea regarding how to interpret an ultrasound of the maxillofacial area, so probably you are best placed by ordering these plain X-rays and basing your diagnosis based on that. Ultrasound, where it is appropriate, also has no radiation over here. All right, ultrasound has no X-ray radiation involved. So this is also another reason why this document reported gave it a maybe appropriate reading. Other X-rays you can see over here, MRI maxillofacial, CT maxillofacial with contrast, CT head. So those are considered to be not appropriate in such cases. So they had a specific paragraph on radiography of this report, had a specific paragraph on radiography. So I just want to share that paragraph here with you. So for injuries of the midface, CT has largely replaced radiograph. And if any of you have studied the 3-volume Fonseca oral and maxillofacial surgery, so though that book recommends that for evaluating midface trauma, you should have slice thickness. You should order a CT scan and order a slice thickness of about 0.625, 0.65 to 1.25 mm slice thickness, because your midface has a lot of small thin bones. So if you order a very small slice thickness, then you'll be able to see all of them. Otherwise, if you order a bigger slice thickness, like maybe 5 mm, 8 mm, so then you just miss a lot of chunks of bone in that, and that will not give you a lot of information. So the limitations with radiographs are primarily related to inaccuracies, especially with small or fine structures. Like I already said, your midface is made up of basically small and fine structures. It is also associated with superimposition of adjacent anatomical structures. So the superimposition is what basically makes it very hard to interpret a plain X-ray. Also, there is a lack of usually technical skill, which can result from disuse and a lack of training. So basically, all the radiographers that you have over here, they're not basically maxillofacial radiographers. So they might not be taking standardized X-rays, and the X-rays that the patient comes up to you with will obviously then be diagnostically unusable. So they actually did one study in which they compared CT with plain X-rays, and they found that radiologists actually missed 12% of fractures on radiographs as compared with CT. So they were more capable with diagnosing fractures or picking up fractures on CT as compared to plain X-rays, and 12% is quite a huge number. However, when you combine your physical examination with the Waters view, a Caldwell view if indicated, and a submental vertex view, you can get sufficient information to verify the clinical diagnosis of a zygomatic-maxillary complex fracture. So like I said, with plain X-rays, you can diagnose a fracture, but you can't really treat and plan a fracture. That is the major reason why we opt for CT. Still, both, like I said, patient positioning and technological experience are essential. Radiographs may be useful in identifying and determining the location of foreign bodies in the maxillofacial region. This is the only case in which a radiograph is better than CT, because in CT, when you are coming across a maxillofacial trauma patient where you're suspecting foreign bodies, like a patient has had a firearm injury. So that firearm, basically a bullet lodged in the maxillofacial region, you know, a bullet is made up of metal. So metal, whenever you do a CT scan of an area which contains metal, so that metal actually produces some artifacts which make it very difficult to interpret that CT scan. Those artifacts are called beam hardening artifacts, scatter artifacts. So it is very difficult to then actually see what you're looking at in that X-ray over there and that CT scan. So if you want to just locate a foreign body, you can just order 2 plain radiographs, and they can help you somewhat in locating that CT scan. Okay, so we have a question here. CT is gold standard, but if anyone asks us about it, we do operate on basis of radiographs in many cases. Yes, that is very true. And for exam purposes, if you come across a mid-face fracture, I would always recommend that you ask the examiner for a CT scan. All right, because you are always supposed to order the gold standard. If the gold standard is not available, then obviously you will have to rely on the X-rays that you just have. And the reason I told you why we don't do CT, but we operate on basis of radiographs is again mostly patient finances and the lack of a CT scan available in our emergency rooms. All right. In cases where even we do have CT, what the radiologists basically do, they just do a CT scan of the head just to evaluate brain trauma, but they don't extend the field of view up to the maxillofacial area. So those areas are then not scanned. So CT obviously gives a lot of radiation dose to the patient. So if you're just going to send a patient for another CT scan, number one, it's going to cost him money. All right, CT scans are not cheap. I think they cost about somewhere in the region of 3,000–4,000. So for the majority of our trauma patients who are basically working at the poverty line or even below the poverty line, that is a lot of money for them. And secondly, obviously, you'll have to consider about the radiation dose, although there is no consensus on how many CT scans you can order simultaneously or how quickly you can do a CT scan. But still, if you can try to minimize the risk of radiation, especially in pediatric patients, then that is more prudent for us to do. Okay, so I hope that question is cleared up. So I think that will bring us to, yes, that brings us to the end of session 1. So does anybody have any questions? Because I have about 7 minutes till this meeting ends. So if there are any questions, I can take them now. You can also take the questions in our group if you want. You can message them privately as well if you feel shy about asking questions or if you feel that your questions are stupid. But don't worry. Like I tell all my course participants, you're all learning over here, including myself. So there is no such thing as a stupid question. So what in my opinion is stupid is that if you have a query and you choose not to ask it just because you are shy. So don't be shy. None of us are geniuses over here, including myself. And we've all learned this through asking questions, no matter how stupid they may sound. So for the sake of your learning, please be bold, don't be shy, and do ask questions. All right. Okay. Oh, we have a question over here. Okay. Whether the position for radiographs will be decided by the technician or OFS person. Since X-rays are ordered by the surgeon, so they are not decided by the technician. All right. You have to basically guide the technician of which X-ray you want and in what angle you want. So that has to be decided by you. In the ER, there are no X-rays done in the ER. You have to do a CT scan. All right. So that is done by the radiologist. So for the radiologist, again, you have to guide him that which areas do you want to be scanned. All right. So in our setup, mostly what we see is that even that the radiologist usually just scans the head just to evaluate brain trauma. And that's fine, then they don't scan the maxillofacial area. But that is usually because maxillofacial surgeons are not a part of ER in most of the centers, to my knowledge, in Pakistan. So since they are working separately in their own departments, so that is why we order plain X-rays instead of usually ordering CT scans. But in ER, usually a radiologist is present and they do a CT scan, which takes just maybe 1 to 5 minutes maximum. So you can do almost a full body scan if it is indicated, and that will obviously cover the maxillofacial area as well. Okay, Dr. Numan? And most of the time, X-ray are not interferes come across as defined in the we just get a rough image. Yes, that is very true, and that is the reason I mentioned this report, in which it has mentioned that technical skill, experience, these are things which are very important. Plus, the bookish images that you are seeing, those are all digital X-rays, and in most of the time, those X-rays are not digital; they come out on the conventional film, which is again not very clear. So that is the reason why we have trouble interpreting those X-rays. All right, we have another question. Lateral X-ray, the one you told us about in the end, is not usually practiced. Yes, it's quite rarely practiced. In fact, we only get such X-rays from patients who are in the periphery. They might have done this X-ray for evaluating the, head trauma, or that is usually not practiced over here. Usually, we depend more on the water's view and other X-rays. Yes, I'll show that X-ray. Lateral skull. Here we have one over here in which this looks right like a lateral ceph. Hang on, is this clear? I think this one is more clear. Yeah, this is the true lateral skull. Like I said, it's basically a non-standardized lateral ceph. So I'm sure you've seen a lateral ceph. So this is basically that. The only thing is it's not standardized. You don't have those ear pointers that the patient has to put in their ear and any other markers. So the patient's head position is reproducible in case you want to take an X-ray after a few months just to see the outcome of your orthodontic treatment. Yes, exactly. It is basically a non-standardized lateral ceph. And again, we are not very fortunate. The only X-rays that we used to get of true laterals were on those old conventional films, not digital films. So those are not usually diagnostically very useful for us. So we still used to send the patient for a water's view or some vertex view if it was indicated. All right, any other questions? Because this meeting will end in about 2 minutes. So if there are questions, then I'll restart the meeting. If not, so then I'll end the meeting over here. Recently, a fracture at FZ level is not obvious on a CT, and we came across what the open slices were 1 mm. Well, if you can share that picture, I'll have a look myself and see if it was obvious or not. Plus, it's possible it was maybe a non-displaced fracture, so maybe that's why it was not visible, or maybe you were looking at a wrong window. Fracture should be visible in a bony window. Maybe you're looking at the soft tissue window. So on soft tissue window, you can't see the fractures very clearly. Dr. Nohan. Yes, if it is non-displaced, then it probably will be difficult to see. But if you can send us a picture of that in the group, if you have it, so then probably we can see. It was bony window. Well, then probably again, since it was non-displaced, that is the reason you were not able to see it. And this is one thing that you will always see written on a CT report, that these clinical correlation is recommended. So don't rely purely on X-rays. You have to combine it with your physical examination findings. Then you can come to a diagnosis. Just don't rely on an X-ray, because there can be artifacts which can or maybe the patient has moved or something. So you might not be able to check, might not get all the information that you want. Okay, thank you, Dr. Sagwar, thank you, Dr. Noman, and thank you to all the other participants. I hope you found this lecture useful. Inshallah, I'll try to upload the recordings by night, inshallah. Still, if you have any questions, please do share them at the group. All right. So have a good day, and see you at the next webinar, inshallah.